Hi, this is Dr. Ash. I hope you guys are enjoying your weekend. As you know, that today is Sunday and we are enjoying at home. I was just a bit free, so I said, let's conduct some teaching activity for all our PEMA doctors and junior doctors of Pakistan and all across the world. So, as you know, that in the last 2 years, we have conducted so many activities from PEMA platform on site from Karachi, Lahore, Swat. But now, due to pandemic, it's very hard for me to conduct those activities on site. So PEMA is now bringing a new project for all of you, which is hot medical cases. Uh, what are the hot medical cases? You know, we do so many reviews on medical patients. We see hundreds of patients, but not all of them are actually so eye-opener and have so many teaching points in it. So there are only few patients which have so many learning. Although you can learn from all patients, but there are few patients which can actually give us a lot of opportunities to learn from them. What I'm trying to do now, uh, I'm going to make a list of those cases which I see in my day-to-day clinical practice, and I'll bring it to all my juniors maybe once or twice a week. As you're all aware that I used to be a medical emergency medicine consultant for 4 years, and I did emergency medicine for 10 years. And I recently moved to acute medicine, and it's really very important. I should share how I am doing in acute medicine as well. And inshallah, if the life permits, we will continue to share our knowledge of emergency medicine and acute medicine with you all. So, uh, these are the hot medical cases. This is the case one, I would say. So, this was a 82-year-old male who presented to emergency department with feeling lethargic. For 2 weeks, he has no energy at all. He was unable to carry out routine activities. Found to have a low blood pressure, 88/50, which is quite low. With this presentation, his past medical history uh, was hypertension, diabetes, prostate, and metastasis of the prostate, which in April 2019 showed a progressive disease on MRI. He had a cord compression, cord equina symptom as well in the past. He was admitted for radiotherapy at that time, and then later on he was switched to hormonal therapy, which is the dexamethasone and diethylstilbestrol. His CT scan of the thorax and abdomen in February 2018 didn't show any advanced disease. It shows a stable metastatic disease as it was in the past. So imagine this is a patient who is 82-year-old male with a complex kind of, metastatic prostate disease, already on steroids, coming with tiredness, weakness, lethargic, and with hypertension. This was his main presentation. He also complained of some faintness and dizzy episodes. These were his medications. Interestingly, he was on sitagliptin, which is for antidiabetic. He was taking dexamethasone for his prostate and metastatic disease. Ramipril, which is antihypertensive. Bumetanide is again diuretic. Furosemide kind of medication where you have a water diuresis, and this was his medication history. Now, I had to keep this presentation very short so that I can give you the essence of what we learned from him. So, his social history was reasonable. He lives with his wife. He was walking with a stick, and he was able to climb on, stairs and independently. Now, with this presentation, 82-year-old with kind of history of prostate cancer, had a radiotherapy, he is now on some chemo medications and hormonal treatment, dexamethasone. Now he presented with all these symptoms. Thoughts? What were the thoughts? Of course, there was a long list of thoughts. Is it blood pressure low due to dehydration? Is it blood pressure low due to something cardiac event? Is it a neurological? Has the cancer metastasized to some sympathetic nerve? What is it? A neurogenic hypotension, or there is an endocrine element to it. So these were all we were thinking. He was on lots of medication as well. So we were thinking that whether his medications are causing him hypotensive. Is he dehydrated? What's his physiological decline or just the general decline? So there was a long list of thoughts which were going in my mind. This is the beauty of medicine, that when you work as a medical consultant, you have to do a lot of brainstorming. Now, on examination, there was like CVS was essentially normal, and except hypotension, there wasn't any finding. His JVP was normal, and there was no skin pigmentation. His lying standing blood pressure did not show any postal drop. CNS did not show any focal neurological deficit. There was no visceromegaly as such. There was some gynecomastia, which I believe may be due to his hormonal treatment. Now, with this presentation, of course, we did the bedside investigation, which shows VBGs, which is called venous blood gas. I think in Pakistan and other countries, they are still doing the ABGs. So this is the bedside investigation, which shows that his pH was 7.26, which is quite acidotic, and his PCO2 was 5.4. His lactate was 2, his blood glucose was 5.7, and his bicarbs were very low. So he was having a metabolic acidosis. Now, full blood count was hemoglobin was stable, HB MCV was fine, and his sodium was 135. Potassium was slightly a bit high, 5.8, and urea was significantly high, which is and creatinine was very high. So there was an acute kidney injury, which we believe was due to pre-renal, due to dehydration, because he didn't drink much. That could be the cause. And persistent hypotension, he was persistently hypotensive, so this could be due to hypoperfusion. But the rest of the bloods were quite okay. Now, looking at this investigation, if you see someone with the acidosis, hypoperfusion, you have mild hypokalemia, what would be your thoughts? So anyway, irrespective of the thoughts, he was given normal saline, a bag of fluid, potassium was the treatment, hypokalemia was treated. We stopped all his antihypertensive, see whether they may be the cause of his low blood pressure. Now, his AKI improved, but patient was still hypotensive. His blood pressure still remained low, and his blood gases slightly showed improvement with pH of 7.3, but he was still mildly acidotic. But his potassium got worse from 5.8 to 6.2, and his sodium went back, dropped from 135 to 126. His bicarbs were 16, so persistent, like same, and his creatinine improved, but his hypotension persisted. Now, looking at this patient who had all medication, all the treatments done, fluids given, he had medications, antihypertensive medications were stopped. Kidney functions improving, but his blood pressure was not improving. So what was the cause of that? We also looked at that his sodium dropped, the potassium went up. So in summary, patient has a metabolic acidosis, he had a hyperkalemia, hyponatremia, resolution of AKI, and persistent hypotension. Now, his last CT scan of the chest, abdomen, pelvis didn't show anything significant other than he had bilateral adrenal gland masses, which were already known there, and there was no evidence of further progression of the metastatic disease. He had known to have a body metastasis of the prostate. Now, so his metastatic disease was quite stable. What could be going on to this patient? We were doing the brainstorming that why his blood pressure is not improving, and because he's already on dexamethasone, so we were thinking, okay, even if it is Addisonian crisis, he's already on dexamethasone, so and he doesn't have a hypoglycemia. His sodium was normal on arrival, so but there are adrenal masses there. Of course, Addison crisis is the top of the list in the treatment. So what we did, we doubled the dose of dexamethasone from 2 milligram to 4 milligram, because normally what it is said that if the patient is on a steroid and he comes in Addison crisis, just double the dose of the steroid. We sent the full endocrine screen, and we found out that the patient was in Addisonian crisis. And we were happy that we made a diagnosis, and then we started treating him. And now we were expecting that his blood pressure will improve next day, but unfortunately, his blood pressure was still low, And it was a mystery now. Finally, we discussed this case with the endocrinologist. We said, okay, it's been a few days. Let's talk to endocrinologists, what they say. And guess what? Endocrinologists, they won. Uh, they took us back to the basics. What is the basics? The basic is that this is the renin-aldosterone mechanism. And you know that this is nephron, PCT, loop of Henle, this is DCT, and this is the place where mineralocorticoid aldosterones they act. Now, uh, this guy clearly had a deficiency of aldosterone with low sodium and high potassium, so he was unable to absorb the sodium. That's the reason his potassium was still in the system, in the body. So he was having a hyperkalemia, hyponatremia. Now, why his aldosterone was still low? Because we were already giving him dexamethasone. We gave him double the dose, and we all know that dexamethasone is the strongest steroid. So anyway, uh, the take-home message was this chart. So if you look at this corticosteroid conversion chart, you know the dexamethasone is the strongest kind of steroid. So 0.75 milligram of dexamethasone is actually equal to 25 milligram of cortisone. So and 20 milligram of cortisone. So it's a very strong steroid. So strong doesn't make difference, isn't it? Look at that dexamethasone. It doesn't have mineralocorticoid activity. It has a glucocorticoid activity, but it doesn't have mineralocorticoid activity. So this was the catch point. And if you look at the hydrocortisone, it has glucocorticoid activity as well as mineralocorticoid activity. All right. So what was happening? We were giving him dexamethasone. We were giving him a medication which didn't have mineralocorticoid activity. And we all know from our medical knowledge that any patient with adenosine crisis, give them hydrocortisone, give them fludrocortisone. We all know that. But here he was already on dexamethasone, and the impression came that okay, dexamethasone is a steroid. Let's double the dose of steroid. Now, increasing the dose of dexamethasone was not useful as it doesn't have mineralocorticoid activity at all. It's a potent glucocorticoid. So the drug of choice is either fludrocortisone or hydrocortisone. So we started him on fludrocortisone, and next day patient felt better. He improved, his blood pressure improved, and he went home with the follow-up oncology and endocrinology. Now, this is a really important case. Why it is important case? Number one, it's hard to diagnose Addisonian crisis in the very first place. Then once you make a diagnosis, then treatment, and then reviewing the treatment, whether it's working or not working, and reaching to that point. There are a few take-home message from here, which is when will you suspect Addison's crisis? Any patient who is presenting to you with a generalized tired weakness which you cannot explain, think of Addison's crisis. Any patient who is diabetic, because autoimmune, diabetics, and thyroid, they all can coexist. Any patient is already on steroids like prednisolone, due to which he's using for rheumatoid, or steroids for his COPD. Think of Addison's, that all of a sudden in acute illness the steroid requirement goes up, and patient initially may not present classical symptoms. So yes, we know that Addison's crisis patients have hyponatremia, hyperkalemia. But what if patient is dehydrated as well? So his sodium will be more concentrated, and you may get the normal sodium. So when you gave the fluid, at that time actually you found out that he was hyponatremia, when all the fluids, salts were diluted. And you may think, oh, blood glucose is normal, but think whether this patient is diabetic or not. So this was a diabetic patient. So for him, normal glucose 5.7 is not normal for him. He is basically hypoglycemic based on his diabetic history. So a diabetic patient, blood glucose may be normal. So that's hypoglycemia for them. Hyponatremia may be masked due to dehydration and get unmasked as soon as you correct the dehydration with the fluid. So important thing here is make sure that you don't miss the basics, and remember that dexamethasone has no mineralocorticoid activity. Addison should be treated with hydrocortisone and fludrocortisone. A specialist advice should be taken as soon as possible. because it's a potentially life-threatening illness. And remember, good basics never fail. So if you are stick to your basics, you will never fail. This was a wonderful case. I thought I should share with you guys for the learning purpose. Hope you enjoyed this session. Please leave your feedback on PEMA Facebook page. You can also write the feedback in the comments in the video below. Subscribe this channel now, and you will get one hot case every week, and you will learn a lot from us. And these cases are those which we're actually teaching and training in United Kingdom to all our trainees. So they are the part of your curriculum. If you're training yourself in a medical specialty, if you're going for MRCP, these cases will be there. And I wouldn't be surprised in the near future these kind of things may appear in MCQs in MRCP, because Royal College invites MCQs from the doctors who are working in the UK, isn't it? So this can be a kind of MCQ. This can be a kind of clinical based discussion. So remember uh, not to forget the feedback, and please join us on this channel, and you will learn a lot from us. Thank you very much for your time.